Hello and welcome, friends, to this ICS live event on female urethral obstruction. Thank you to the ICS for this opportunity to present this excellent topic. My name is Garson Chan. I'm a reconstruction and a urology fellow in Melbourne, Australia. I'm joined by Dr. Johan Ghani and Professor Helen O'Connell. This event is part of a series of live streamed content prepared by the ICS. You can see the other live events scheduled on the ICS website, and we invite you to be part of the discussion today by adding your comments to the section below in the website. We will read and respond to the questions as they come. So to start the session, I have no disclosures. And this is our agenda today, and I will introduce both our speakers briefly. Female obstruction we'll touch briefly about, and then dive deeper into female obstruction after anti-incontinence procedure, which Professor O'Connell will discuss, followed by a discussion on female urethral stricture disease, which will be presented by Dr. Ghani. We will discuss several clinical cases, and then finally, we will address any questions during the broadcast if there's time. Otherwise, all the questions will be answered online. Female outlet obstruction is quite under-recognized and under-treated. And in one recent study, actually, almost 20% of women with LUTS had some form of obstruction. And unlike men, obstruction is poorly defined, but in general, the concept is similar. Those with high pressure, low flow, and high residuals. And under this umbrella term lies a variety of differential diagnoses. These number of issues can include dysfunctional voiding, DSD, detrusor underactivity, bladder neck obstruction, Fowler syndrome, stricture disease, which we'll talk about, as well as anti-incontinence procedures or vaginal procedures, prolapse, malignancy, the list goes on. Today, we will focus on specifically female urethral stricture disease and obstruction post-incontinence surgery. Now it is my pleasure to introduce Professor Helen O'Connell, who will discuss further the topic of obstruction after anti-incontinence procedures. Professor Helen O'Connell is an academic urologist based in Melbourne, Australia. She is the professor in the Department of Surgery at the University of Melbourne, the past director of surgery and current head of urology at Western Health in Victoria. She is a leading researcher in the area of female pelvic anatomy and remains actively involved in both clinical and basic science research. She is also the urology clinical lead of the newly created Australasian Pelvic Floor Procedure Registry. Professor O'Connell is the chair of the forthcoming International Continence Society meeting in Melbourne in 2021. Now I'll turn over control to Professor O'Connell.
Thank you so much, Dr. Chan. And I'd have to say, as part of a webinar put on by the ICS, that we're delighted to have a fellow from Canada. We've had some wonderful international collaborations, but I'd have to say our Canadian fellows have been more than first class, and we'll miss you very much. Garson's about to finish his 2-year fellowship with us. If the images are in the way at any stage, I apologise, but I'll see if I can make sure that the screen is very clear at all times. So as Dr. Chan said, I'm going to be focusing on slings as a cause of urethral obstruction, and of course it's become the most common cause of urethral obstruction in women, and not a particularly uncommon cause as well. I have no relevant disclosures. And so as part of this talk on obstruction related to slings, I'm going to refer firstly to the immediate post-sling relief of obstruction surgery, a relatively common situation where people have lower urinary tract symptoms following a sling, but they haven't had immediate sling release. And so then there's the issue of early versus delayed relief of obstruction, how we actually do the surgery, and then I'll refer to some material about prevention of sling obstruction as well. So sometimes it's absolutely clear cut, isn't it? Patients are in complete retention following their sling. They've got very poor flow, high residual or absolute retention. And it has become clear that what the management of that situation is. But often it's a lot less obvious, and I'll discuss later the reasons for that, but the presentations may be of a refractory overactive bladder and poor response to overactive bladder treatment, including onabotulinum toxin, new onset in the presence of pelvic organ prolapse, which could be exacerbating what was previously mild, and occult bladder outlet obstruction. Sometimes the presentation is of persistent stress incontinence, which exacerbates bladder outlet obstruction. And there's a good study that demonstrates that up to 1/3 of cases of painful bladder syndrome, the basis is bladder outlet obstruction. Also, the very common cause of urinary tract problems in women is recurrent urinary tract infections, and sometimes the basis for that may be a sling procedure that occurred long ago and has been potentially forgotten, even by the woman herself. So persistent or recurrent urinary tract infections, we should be considering, could the basis for that be urethral obstruction? Where urethral dilatation seems intellectually like a good idea, it doesn't work, and it can lead to other problems, including fistula. So just from the point of view of a basic principle in female urology, urogynecology, I trained in the US. No matter what you say about urethral dilatation, there's a very small place for that procedure, full stop and period, if you are living in the US. So let's move to the situation of immediate sling release. Rautenberg has published a number of excellent papers on this, and I will borrow some of his images, which are excellent about this topic. But it's clear from a huge series of his patients and a number of other studies as well, that early release of a sling, if patients are in absolute retention, is very likely to restore voiding function and normalise voiding function following a sling procedure. What was very useful about Rautenberg's work was looking at the predictability of the distance between the tape and the longitudinal layer of the smooth muscle. And if that distance is 3 millimetres or less in the presence of a residual volume of 100 cc's, that restoration of voiding can be expected. And that was associated with a relatively low risk of recurrent stress incontinence. So if we have a look here, you can see the TBT against this longitudinal smooth muscle. And if that distance is small, and you can see there's a sort of distortion associated with that relative to this image where there is no distortion, that is the situation that's associated with ongoing voiding dysfunction and should be considered for immediate sling release. This is also a very clear slide from that surgery that you can perform an immediate reopening of the incision and gently place traction on the sling to bring it down. We've also had some experience with this. My mentor in the US, Ed McGuire, would sometimes even in the clinic reopen a small incision, the sling incision, and release the sling if someone was in absolute retention or was in a severe voiding situation, and this was temporarily associated with placement of fascial sling. Nguyen published a large series early indicating that up to 10 days a sling can be mobilised And we would argue that that's appropriate, particularly if the patient has absolute retention. Obviously, that's not the only situation. It's not perfect, but it runs a very low risk of recurrent stress incontinence, and could be advised in that situation of absolute retention. An interesting study that is probably rarely used, but does speak to the original technique of Umstead being associated with a high cure rate, but you know, in some series, acute retention rate as high as 15%. Most of the time, people make slings relatively loose, but this was an interesting study in that they tensioned the sling immediately post-operatively, so that if patients still had stress incontinence, it could be tightened rather than the other way of what we do today is try to leave it reasonably loose, and then have a very low rate of retention post-operatively. Raperda, in a multi-centred study, I'll see if I can move that box out of the way, looked at failure to void in a large number of patients, and most patients will in fact pass a second trial of void, 90%, 40% will pass a third. Risk factors associated with failing that immediate voiding trial or persistent voiding dysfunction include pelvic organ prolapse with retention in up to 35% of cases. Comorbidities are associated with high rates of voiding dysfunction, and the long-term sequelae of bladder outlet obstruction include overactive bladder and recurrent urinary tract infections. The most appropriate thing is to, if you have recognised voiding dysfunction and persistent high residuals, it may be exchanged by patients with now in that sort of 3-month phase having new onset overactive bladder with relatively poor voiding, but their voiding may start to compensate, and the more obvious symptoms are the so-called de novo overactive bladder symptoms. But this syndrome of initially poor voiding, relatively poor voiding, and new onset overactive bladder syndrome should be treated with early obstruction. Not releasing it is associated with long-term urologic morbidity, increased anxiety, possibly the need for intermittent self-catheterization, and certainly the risk of recurrent urinary tract infections. A number of studies have demonstrated the benefit of early versus late relief of obstruction. Leng's work, South's Brubaker's work, it's supported by guidelines that there are long-term complications associated with delayed sling incision and the probability of a worse outcome. So why wouldn't you march on to do a sling release procedure? What would hold you back if the data is compelling that a delayed relief of obstruction is not as good? Well, firstly, it's often a problem of lack of recognition. So firstly, in many countries, long-term systematic follow-up of patients hasn't been expected. And at 6 weeks, patients may appear to be improving. They may have ticked enough boxes that we discharge them from care. I mentioned de novo overactive bladder symptoms, which may increase with relatively mild partial obstruction over the years, and the link to the original surgery may be lost. Of course, they may not present to the original clinician, which is a common issue. They then present, to a new general practitioner. The patients themselves may also not be fully aware that they've had sling surgery, particularly if it's been part of a pelvic organ prolapse operation. And then, of course, there is a legitimate fear that the original surgery will be associated with recurrent stress incontinence, but actually that fear has probably been overstated, and the risk of recurrent stress incontinence is less than 20%. So what is that? So in a large series, this is of fascial slings with sling lysis. The recurrent stress incontinence rate was about 17%. One of the things that has been observed by Thiel et al. Is that actually the stress incontinence risk appeared to be worse with delayed incision compared to early sling incision. In terms of predicting stress incontinence, it's apparent that if patients have stress incontinence after their initial procedure, they are much more at risk, if we do then a sling incision, of having considerably worse stress incontinence. And then there's the issue, if you're doing a incision and someone already has stress incontinence, should you combine it with a autologous fascial sling, or should you do a staged procedure? And David Ginsberg, Eric Grosvenor and colleagues looked at two approaches, and it was clear that at a prolonged follow-up of mean follow-up of 16 months, that 91% of patients were voiding and had good continence in the patients who had a combined procedure versus 76% in patients who had had the staged procedure. So certainly a registry is a great approach to following up patients consistently, so that we know if they have persistent voiding dysfunction and refractory overactive bladder, and should be considered for urodynamic studies to characterise whether or not they're obstruction. Patients with refractory overactive bladder should be asked clearly if they've had sling surgery and if they've had a history of retention. If patients have pelvic floor muscle overactivity, which may be indicated by difficulty with catheterization or a tender pelvic floor in the presence of poor flow, should be referred for physiotherapy. When we're doing urodynamic studies following a sling, asking the question, does somebody have bladder outlet obstruction? We look firstly in the filling phase, do they have a wide open bladder neck at rest, and test them at half of their bladder filling, or certainly not at capacity, to see if they have intrinsic sphincter deficiency. You'll see a case later of sling obstruction where the bladder neck is elevated at rest. This can be particularly the case where someone's had a pelvic organ prolapse operation at the same time. During our urodynamics, we want to see is bladder storage function normal. Certainly poor compliance is a common feature of bladder outlet obstruction. Obviously, we want to know what the Qmax is at PD at Qmax, the pressure at maximum flow, and most of all, we want to see what the urethrogram looks like during voiding. So this is a patient who has in their filling phase intrinsic sphincter deficiency. So this is a patient with severe incontinence following a sling procedure. They've actually had a sling division procedure as well, but you can see in the storage phase getting a Valsalva lead point pressure of 80 centimetres of water, and then during the voiding phase over here, a high voiding pressure with a pediatric Qmax of 35 centimetres of water with a flow of 13 cc's per second, but you can see that they're obstructed during the voiding phase despite having had a previous sling incision. How do you do the surgery? Well, you can, particularly if the anterior vaginal wall is healthy and pliable, just reopen the original vaginal incision and make an incision through the sling in the midline. Where the voiding dysfunction is more complex, you're more likely to benefit from doing a urethrolysis, which we would tend to do as a bilateral incision. So the more complex patients who, particularly following fascial sling surgery, we would tend to do a bilateral incision, or where you're worried about development of worsening stress incontinence and the bladder neck is open. I've certainly seen terrible stress incontinence where you go back and have a look at patients' original urodynamics and they had a wide open bladder neck, and that situation is not made worse by doing a bilateral incision. Should you send a segment of mesh off, or it could be fascial sling? One of the patients I was called about by a pathologist, I was contacted on the basis of the tissue that I'd sent off teeming with gram-positive bacilli, and I've made it my practice since then to always send off a specimen for culture and histology. You know, you're not going to know unless you do these things systematically, and it doesn't need to be a significant amount of tissue, but there is definitely a case to be made for sending off some tissue, particularly if there's any doubt in redo situations. You can see here, this is a patient who's previously had an anterior vaginal repair, and the tissue at the anterior vaginal wall has been closed under some tension. You can see a sort of, I've highlighted a bubble from a synthetic mesh that's almost eroding through. And in situations like this, you can use a inverted U type incision, inverted Y rather, and then advance the vaginal wall distally to cover the area that is narrowest. Voiding dysfunction typically resolves, though you may be stuck with overactive bladder, which follows a slower time course, as we see with prostatic obstruction. But you may then find that overactive bladder treatments now work. If someone has terrible or very severe overactive bladder, it may be difficult to even get good enough voiding function studies because the storage isn't adequate. And then the other point about stress incontinence afterwards will often respond to an injection if it's relatively mild. One thing that's worth being aware of is data that Johan Garni was the lead author on. So this is from a large series where we looked at tensioning of the sling. So this is the tying off of sling sutures at the time of fascial sling surgery. And this has been, in terms of preventing sling obstruction, incredibly helpful. So it hasn't completely resolved any voiding dysfunction, but it almost has completely resolved that problem by using at least 4 centimetres of sling tension in closing off the, in tying the sling sutures at the time of surgery. I'm going to leave our presentation there and hand over to Johan for his presentation on strictures.
Great, thank you, Professor O'Connell. Now I would like to introduce Dr. Ghani. Dr. Johan Ghani is a urologist based in Melbourne, Australia, with an active clinical and academic practice and has won awards and grants for his clinical research. He is a consultant at Western Hospital and Austin Hospital, where he is the Functional Urology Fellowship Director, and his research interests vary from fields of avoiding dysfunction, neurourology, prosthesis surgery, sacral neuromodulation, and female urology. Dr. Ghani will discuss female urethral stricture disease, and I'll turn it over to you now.
Thank you, Garson. Welcome again, everybody, to our session on ICS Live, Management of Female Urethral Obstruction. And my talk will focus more on the female urethral stricture. So I have no disclosures. So the female urethral stricture is an uncommon condition, and female bladder outlet obstruction alone is quite uncommon. The female stricture represent about 4 to 13% of these cases. So that makes the true incidence of female urethral stricture at about 0.1 to 1%. There's no widely accepted definition. An anatomical definition has been described as a fixed narrowing of the urethra less than 14 French in size that does not allow adequate catheterization. Radiologic definition has been described as a proximal urethral dilatation with distal narrowing. Because of the relatively rare occurrence of this condition, there's not much in the literature about a consensus on investigation and management. So presentation is variable and can include voiding symptoms such as poor flow, hesitancy, dribbling, sensation of incomplete emptying. It can also include storage symptoms, which is usually from secondary overactive bladder from the outlet obstruction. Patients can present with recurrent UTIs, and they can sometimes have urethral pain, especially when passing urine, and sometimes have been misdiagnosed with the urethral syndrome. Patients can have a history of difficulty catheterization, and some of them can present with overt urinary retention. So because of this widely variable presentation, a clinician needs a high degree of suspicion to be able to diagnose this condition. There are multiple causes for the female urethral stricture, and they include infection, childbirth, trauma, and iatrogenic causes, often with instrumentation and catheterization, previous urethral surgery, and also radiation. So when a patient presents to us, we need to do a proper focused vaginal examination, mainly to look out for meatal stenosis, any concurrent pelvic organ prolapse, any periurethral abnormalities, and also the quality of the surrounding organs, especially looking at whether there's any vaginal mucosal atrophy or surrounding lichen sclerosis, as this can impact on the future management of this patient. So there are various investigations described in the literature. A midstream urine sample can rule out an infection. Ultrasound is a good screening tool that can be used to check for raised post-void residual volume. And a uroflow study will give a typical protracted plateau-shaped curve, as we usually see in a patient with a urethral stricture, as shown here. Now, urethrostomy or cystoscopy is very important. However, in some cases with severe strictures, this may not be entirely possible. This is a cystoscopy of a patient with a distal stricture, and as you can appreciate, when the scope is going in, there's a tightness to it, and as we approach more proximally, the urethra opens up. So urethrogram is also very helpful. Now, in a woman, because of the short urethra, retrograde urethrogram is not practical. An antegrade urethrogram can be done through a suprapubic access, or more commonly with a transurethral 5 French catheter that we can insert during urodynamics. We are looking out for an open bladder neck, a dilated proximal urethra, a narrowing at the stricture, giving us a wine glass figure. And this allows us to assess the length and location of the stricture. MRI of the pelvis has been done, but it probably has a low diagnostic value because of its low sensitivity. The main thing to look out for is whether there's any periurethral fibrosis. As you can see in this picture here, even though the report mentioned periurethral fibrosis, it can be quite hard to appreciate. The role of MRI is mostly to rule out other urethral pathology, such as urethral diverticulum or an abscess. The urodynamic study, especially combined with fluoroscopy, is very important. During the filling phase, we can look out for any secondary detrusor overactivity. And in this patient, during the voiding phase, she has a high pressure, low flow pattern. And at the end of a void, she had some abdominal straining and actually expelled the bladder transducer line. And she managed to void a little bit more from that. So the fluoroscopy is in fact an antegrade urethrogram, and that's very helpful when combined with the urodynamics. Before we move on to any surgical management, we need to understand the terminology, and this is really based on analogous techniques of reconstruction in a male urethral stricture. So when we're talking about the dorsal aspect of the urethra, we're referring to the 12 o'clock position or the clitoral position. The ventral aspect of the urethra refers to the 6 o'clock or the volar position, and the anterior vaginal wall just lies underneath this. The female urethra is about 2 to 4 centimeters in length, and it's surrounded by 2 layers of smooth muscles, which thins down distally. Outside this lies the striated sphincter muscle, which extends the whole length of the urethra, but it is really quite thick at the mid-urethra area dorsally, so it gives us a horseshoe shape. And the pubourethral ligament is also part of the continence mechanism. Again, this is also located mid-urethral and dorsally. So with any dorsal urethral approach, surgical approach, there's always a potential to injure the continence mechanism. Treatment considerations should take into account the location of the stricture. This is often divided into distal, mid, or proximal urethra, the length of the stricture, whether we're considering a flap or a graft, or ventral or dorsal approach. Other peri-op considerations: preoperatively, if a patient has mucosal atrophy, we should consider intravaginal estrogen therapy. Patients should be counseled about possible risk of surgery, including stress incontinence, recurrence of the stricture, or fistula formation. Intraoperatively, a stricturotomy has to be done of adequate size to allow a 20 French catheter. If we're using a flap, we need to ensure good vascular supply. And if we're using a graft, it has to be quilted to a vascular bed if possible. And sometimes we do have to use a Marshall's flap or fascial sling as an additional protective layer. Postoperatively, patients are often put on oral antibiotics, and the indwelling catheter can be left up to 2 to 3 weeks, and some clinicians advocate doing a voiding urethrogram at the time of catheter removal. So treatment is really divided into endoscopic or open techniques. Because the urethra is short, primary excision and end-to-end anastomosis is not viable. The open techniques are divided into where the stricture is located, whether it's distal, mid, or proximal or long strictures, and they can often involve flaps or grafts. So endoscopic treatment is really urethral dilatation with female sounds. These can reach up to a size of 41 French. However, the success rate is quite low, at 47% at 43 months. This is even worse if there's a previous history of dilatation, down to about 27%. If there's no previous dilatation, the success rate is about 58%. There's not much in the literature about the role of urethrotomy or bladder neck incision, and there's really not enough evidence for this, and it can potentially be harmful in some women. So for meatal or distal urethral stricture, the Heineke-Mikulicz meatoplasty is a good option. The stenosed meatus is incised ventrally and longitudinally, and the edges of the urethral mucosa is then sewn to the vaginal mucosa transversely with interrupted sutures. Success rate is very high, 96%. This is only suitable for very short, less than 0.5 centimeter meatal stricture. If it is used for longer strictures, it can cause a hypospadiac meatus and vaginal voiding, and is not advised if there's surrounding lichen sclerosis. A distal urethrectomy with an advancement meatoplasty can also be used in some patients. Again, only if there's a very short distal stricture, less than 0.75 centimeters. This technique is often used for the treatment of urethral prolapse too. So here's the technique for that. So the anterior vaginal wall flap is created, and the distal urethra with the stricture is completely excised circumferentially. The edges of the urethra are then anastomosed to the vaginal epithelium circumferentially with absorbable sutures. So if it is a distal or mid urethra, an anterior vaginal wall flap or the Blendy technique is quite useful. This is suitable if the stricture is more than 1 centimeter in length, but not more than 2 centimeters from the meatus. Potentially if it can cause inward vaginal voiding. This is a recent case that we did. As you can see on the fluoroscopy picture on the left, this patient has a distal urethral stricture. So first the meatus is dilated and the distal stricture dilated. Then we create an anterior vaginal wall flap. A ventral stricturotomy is performed. And once the vaginal wall flap has been created, the apical sutures are placed from the apex of the flap to the proximal edge of the stricture. The sutures are then tied down and the flap is rolled inwards. and the edges of the flap are then sutured to the edges of the incised urethra, and this is what a completed Blendy urethroplasty looks like. The surrounding valval vestibule can also be used as a vestibular flap. Again, this is only suitable for short distal stricture or meatal stricture. This is often done through an inverted Y incision dorsally over the urethra with a dorsal stricturotomy. And once the flap is created, it is swung midline and joined to the urethra. If it is an isolated mid-urethral stricture, the Heineke-Mikulitz technique can also be used. And the concept is incising the stricture longitudinally and closing it transversely. So here, the anterior vaginal wall flap has been created, and transverse incision is made on the periurethral fascia to create top and bottom flaps, and therefore exposing the urethra underneath. The longitudinal incision is created over the stricture, and the urethra is then closed transversely, and the flap is then closed over the top. So for proximal or longer strictures, we really have to think about using longer vaginal flaps or grafts, which can include vaginal epithelium or even buccal graft. So the lateral vaginal wall flap, or the Orendi technique, this is similar to the Orendi technique that's used in a male urethroplasty. This is quite useful for longer stricture. As you can see in the picture on the top left, lateral vaginal wall flap is first mobilized. That's a C-shaped incision. This is rolled to one side. The middle portion of the flap is de-epithelialized. A ventral stricturotomy is then done, and the medial surface of the flap is sutured onto the ipsilateral side of the urethra, and the lateral side of the flap is then closed over the contralateral side of the urethra. So a vaginal free graft can be used if the vaginal tissue is healthy. This can be then placed dorsally or ventrally. This is a technique using the vaginal free graft and placed dorsally, so the urethra is incised at 12 o'clock, and the graft's mucosal surface is then sutured facing the urethral lumen. So if we want to avoid using vaginal tissue, especially if there's lichen sclerosis, we can consider using the buccal graft or the oral mucosal graft. And as we know, it is an excellent tissue for urethroplasty due to its inherent properties. This graft can be placed dorsally or ventrally. This is a technique using the buccal graft and a dorsal onlay technique. So once the suprameatal incision is created, the graft is quilted superiorly against the surface of the clitoral bodies, and the edges of the graft are then sutured onto the open urethra. The distal edge of the graft is then sutured to the edge of the suprameatal incision, and this is what the final result looks like over here. So the buccal graft can also be placed ventrally with an onlay technique. Again, an inverted U flap has been created, and the urethra is incised ventrally. Sutures are first placed for the buccal graft to the edges of the open urethra, and the harvested buccal graft is then parachuted down to the open urethra, and often a Marsh's fat pad is sutured over this graft as an additional protective layer, and the vaginal skin is closed over the top. So next, I want to spend a bit of time discussing our technique that we have published a few years ago. This is a vaginal sparing buccal graft technique that's placed as a ventral inlay technique within the urethra itself. As it does not go through the anterior vaginal wall, it reduces the potential complications such as creating a urethrovaginal fistula. So the urethra has been dilated with female sounds, and using a nasal speculum to open it up, we use a size 11 blade to incise the stricture just at the mucosa to open it up. Then we place 3 apical sutures at the apex of the open urethra. As you can appreciate, the space can be quite narrow there, and often a Turner Warwick needle holder can be quite useful when placing these sutures. So the buccal graft has been harvested, and we then place the 3 apical sutures onto the apex of the buccal graft. And the graft is then parachuted down to lie on top of the incised open urethra. Sutures are tied down. Now, next, the edge of the graft is then sutured onto the edge of the incised urethra. As you can see, we have not gone through the anterior vaginal wall at all here. This is done on the other side. And the excess length of the graft is trimmed off. And the distal edge is then sewn onto the open end of the vagina, the meatus. Finally, the graft is quilted through to the anterior vaginal wall with 6 OPDS double arm sutures, and this is what the final result looks like. So with all these different techniques, which technique do we choose? A lot of it depends on the surgeon's preference and surgical skill set. This is a very nice systematic review that was published in 2013. If you look at it compares the different techniques, including urethral dilatation and different urethroplasty techniques. The mean success rate over here, the urethral dilatation success rate is very low at 47%. Urethroplasty techniques have good success rates ranging between 80 to 94%.
Dr. Ghani, how long do you keep the catheter in afterwards, postoperatively for that?
2 weeks. Now, whether to choose ventral or dorsal approach, the ventral approach is a more familiar approach to the surgeon. It requires minimal urethral mobilization. However, there's a risk of urethrovaginal fistula and ureter injury if we dissect it too proximally. It may also make future incontinence surgery harder. With the dorsal approach, the advantage is we can minimize graft circulation and it can also prevent vaginal voiding. There's good mechanical support. If we are using a graft, the clitoral cavernosal tissue provides a well-vascularized bed as well. It is a preferred approach if we are considering future sling procedures. There's a lower risk of urethrovaginal fistula. However, there's a possible risk to injury of the sphincter mechanism and also to the neurovascular bundle of the clitoris, which can cause sexual dysfunction. So in conclusion, the female stricture is uncommon and a clinician needs a high degree of suspicion to diagnose it. Amongst the different types of investigations, I recommend 2 that are quite essential, the urethroscopy or cystoscopy and the urodynamics combined with fluoroscopy. Urethral dilatation has a low success rate. It is even worse if there's previous dilatation, and urethroplasty should be considered as it has a very high success rate. Thank you.
Great, thank you for that. So we'll move on to some cases to discuss. So first case is a 45-year-old woman. She's had a 5-year history of recurrent urinary tract infections with urethral pain during voiding. She's infrequent voider and avoids voiding to avoid pain, and has some voiding dysfunction with hesitancy, poor flow, terminal dribbling, and incomplete emptying. She's otherwise fit and healthy and has had 5 previous healthy pregnancies. Of note, she's seen multiple providers prior to seeing you without any benefit. She's failed treatment with previous medications. Her urine tests are currently negative, but had a previous chlamydia positive that was treated 4 years ago. Abdominal ultrasound did show a thick-walled bladder, and during cystoscopy, it was very painful and it was tight at the urethra, but the bladder was otherwise unremarkable. Her MRI was otherwise unremarkable. This is her urodynamic tracing with a PDET Qmax of 51 during voiding and a Qmax of 8. She voided 290 and with a PVR of 100. And this is her image at this point. So I'll turn the first question over to perhaps you, Professor O'Connell. At this point, she's had several investigations. Is there anything else that you would consider for this workup?
I would say the urodynamic numbers are very clearly diagnostic of urethral obstruction with the low flow and a high PDET Qmax, obviously a high residual. So this is obstruction. Then we want to go on to see what's going on with the urethrogram, which is your next image. And this is not a picture of primary bladder neck obstruction. This is a long obstruction. It's not consistent with a sling where you get kind of an apple coring effect. Actually, you don't get the hourglass that was present on Dr. Ghani's previous image of a urethrogram, but this is diagnostic of a urethral stricture.
Yes, and so at this point,
in the presence, in the presence of the cystoscopy difficulties.
That's right. And so at this point, what would you consider? How would you manage her? Maybe I'll let you continue, and then Dr. Ghani can have some input as well.
Yeah, look, it's a relatively long-looking stricture, so certainly a distal approach is not going to help this woman. I think, you know, that you should ever only consider one urethral dilatation, and she's seen a lot of people anyway, so it's not an option. So we would be looking at buccal graft mucosa for this buccal graft urethroplasty for this patient. My reading of the literature is it's the most reliable graft source, and I think it's really important. There's so many options out there. These are relatively rare cases. You don't have you know, a bunch of clinicians in a city this size doing it. You have one or two people doing this type of work in a big population, or the patients are referred in. And so I would refer this sort of patient to Johan and one other person in the city of Melbourne.
What are your thoughts, Dr. Ghani, about what you would be doing, or thoughts on dilation?
I agree. This is a very long, dense urethral stricture. Maybe one initial urethral dilatation is probably all that I would recommend if this patient hasn't had it done. We know with subsequent urethral dilatation, the success rate can be quite low. You can even argue for an outright urethroplasty in a dense, long stricture like this. So this lady being quite young, the vaginal epithelium is probably still quite healthy as she's not menopausal yet. So the techniques that can be considered, we can choose a local vaginal flap such as the Orendi technique, perhaps a vaginal epithelium graft or a buccal graft. Now with a buccal graft, we can either go dorsally or ventrally. This patient is quite young, 45 I think, and she's had 5 children. So if the dorsal approach is probably not preferable, as in the future she may need to have anti-incontinence surgery. So if we can, I would like to go ventral approach. And in her case, I would recommend going the ventral inlay technique that I described earlier.
And so going back to the history that both you and Helen touched upon, can you comment on the fact that this patient has seen multiple physicians and had multiple opinions?
Yes, I think that. Oh, sorry. I think that highlights the fact that we all need to have a high degree of suspicion because this condition is uncommon. There are multiple presenting symptoms. If we don't think about it, we're not going to diagnose it. Also amongst our non-functional urology colleagues, they may not be aware that such a condition can exist, or even if they are aware, they may not be aware that urethroplasty is an alternative viable treatment option. So yeah.
I think the other thing to point out, Garson, is if someone's got persistent pain, there is a tendency for them to be written off as kind of painful bladder syndrome or, you know, urethral syndrome, and never actually imaged properly. So this study, you know, takes it out of the kind of voodoo of, you know, a whole lot of pain medicine and actually makes a diagnosis. And the patient potentially has a bright future. So MRI to rule out urethral diverticulum. You know, I had a patient last year with this sort of cluster of symptoms who ended up being a missed diagnosis of a urethral cancer. You know, so it is just so important that we at least think through good imaging. Fluoroscopic urodynamic studies are an investment. You know, they're a bit of, they take work, logistics, but we can do it. And then you get the answer.
Great. So I'll move on to the next case unless there's further questions. This is a 68-year-old female with history of urinary tract symptoms. She's had a previous autologous pubovaginal sling many years ago and had initial history of difficult emptying after the sling placement. This is her most recent urodynamics, which are performed here with showing a PDET Qmax of 58 with a slow flow of 7. She voided 260 with a PVR of 20. And I'll just show you her, if this video will come up, this is her fluoroscopy. So Dr. Ghani, I'll ask you, what would you consider doing for this patient, especially given her fairly late presentation?
So the fluoroscopy indicates an obstructed sling. So this patient needs to be worked up. Does she have voiding symptoms or just storage symptoms?
So initially she had some voiding symptoms, basically a mixture of both.
Yep. So I would work her up to discuss either sling, incision, excision, or urethral lysis surgery in her case, because she's clearly quite obstructed. So she can't keep going on like this.
And as Professor O'Connell mentioned in her nicely presented talk, as many of these has delayed obstruction, can maybe Professor O'Connell initially discuss, and maybe you can comment, Dr. Ghani, about your views as to timing to either loosen, cutting a sling, or urethral lysis formally.
Yeah, so I mean, this is a profound obstruction. They don't often look as obstructed as this. And I think in the early filling phase, it's really important to see whether or not, you've got a bladder neck that's wide open, because if she has pretty good intrinsic sphincter function, then the idea of doing a midline incision is completely reasonable, and she has a very good prospect. I mean, this is a miserable situation, and I'm sure she's got terrible symptoms. You can hardly see any urine getting through, and she's got all the hallmarks of obstruction. But she'll do, I would think, extremely well. She obviously needs to be counselled about stress incontinence, but I think we don't consistently collect data on what's going on with the bladder neck, but it could potentially help us to nuance who's going to get the recurrent stress incontinence afterwards.
I mean, the clear picture of immediate complete retention post-sling surgery, those are quite clear-cut obstruction. In those patients, we can advocate for even just loosening the sling if we can bring the patient back to theatre, possibly within 2 weeks with a fascial sling. I know that beyond that, I've tried loosening a sling at the 2-week mark, and the sling has already been quite embedded into the patient's tissues, so it can be quite difficult to do it beyond that. Now, however, some patients will present late, so we're not going to be able to mobilize or loosen the sling after that. And there's really a bit of controversy as to when we should do this sling incision, excision, or urethral lysis. But I think the message is that the sooner we can do it, the better. Because we know that patients voiding dysfunction, secondary detrusor overactivity, all of those can improve markedly at a higher rate if we try to relieve the obstruction faster.
Right, and in terms of kind of the concern about this obstruction and voiding dysfunction, how would each of you counsel patients preoperatively about this kind of significant issue?
Look, I think this patient is likely to do well from a voiding standpoint. I can't remember the delay between the original surgery and this presentation. But one of the things that I unfortunately see too often is this refractory overactive bladder syndrome, because they're not picked up early enough. I think if you haven't done the original, that early incision, then you probably are committed to waiting for 13 weeks, 3 months. But after that, there's no advantage in waiting, and I think with registries and other vehicles, greater publicity around obstruction syndrome, that we'll see patients coming forward making the link between their overactive bladder issues you know, potentially a obstruction being at the basis for it.
So I would counsel the patient. I mean, the patient would be quite concerned about possible risk of recurrence of stress incontinence if we divide the sling. So the risk I would quote somewhere between maybe 15 to 17% as what's described in the literature. So it is possible. Patient has to be aware of that. However, the success rate is probably 85% to 90-something% of relieving the obstruction. And we know that if the patient has secondary detrusor overactivity, if we do not relieve the obstruction, the patient's not going to get better. And any OAB treatment is often more effective if we have relieved the obstruction.
Great. So in interest of time, I'll just move on to the other case. 60-year-old woman who's had a previous anterior posterior repair with severe, now almost a decade later, severe OAB symptoms, flooding episodes, no infections, no neurological symptoms, no voiding symptoms, but still severe storage issues. She's tried multiple therapies, including bladder retraining, pelvic floor exercises, medications, and initially Botox did work, but now has no efficacy. On examination, no prolapse, can't appreciate any significant hypersuspension, and there's no other tethering that's noted. And her voiding diary does note that it appears she's under drinking to avoid some of these symptoms. Her Uroflow shows a Qmax of 16, which is decent, but a voided volume of only 112 with a 0 PVR. And this is her fluoroscopy image. 2 images there. And then the final urodynamics report shows slightly impaired compliance, no overactivity, no stress urinary leakage, but does show the obstruction as we saw there. And so going back to her history, we actually found that she actually had a TVT sling at the time of her prolapse that she was unaware of. And so similar to our previous case, maybe Dr. Ghani, you can take this. What would you do for her at this point?
So this is quite a tricky patient. She has symptoms of overactive bladder. We've given her Botox at the 3-month mark. She has not had any sustained efficacy. So the first thing we have to think about is the Botox enough, as in the dosage enough. So a urodynamic study at the 3-month mark is often quite useful. So in her case, we found that the Botox has controlled the detrusor overactivity, but incidentally, we found a high voiding pressure. So she's obstructed. So that may explain why her overactive bladder treatment has not been that effective, because there's ongoing obstruction. Also often some patients may not be aware of what they've had in the past, especially the older patients. So we have to think about possible previous sling surgery in her case.
Yeah, that's correct. So she actually underwent a sling division, and her flow actually improved quite a bit. There was some decrease in her urinary frequency, but her OAB was not completely resolved. And so at this point, do you think there's if she's failed medications and she's still having OAB, is there worth another trial of Botox?
Yeah, I've had quite a lot of patients with this sort of scenario, and it is interesting that we should get disciplined and write up. It does look like short-lived responses to Botox do seem to be part of an obstruction syndrome. So if you know, it has made me go back where someone who you expect is going to do well with Botox and then review their urodynamics, or if they haven't had detailed fluoroscopic studies in the first instance, make sure that we have ruled out urethral obstruction. And then it's very interesting, often the responses to Botox once you relieve the obstruction is pretty good.
I agree.
Great. So
great.
Consensus statement there. So I'll turn to our last case as we're running a little bit short on time. So this is a 62-year-old female who's had severe overactivity the past 10 years. She's had multiple procedures, including a remote STEMI needle suspension with a intravaginal slingplasty sling, which is a TVT variant, as well as a removal of that, anterior repair. And she's really had no success with any conservative treatments. This is a fluoroscopic view that was previously shown by slides by Professor O'Connell, which showed the anterior wall cystocele, as well as slightly behind there an open bladder neck that's difficult to see with a Valsalva leak point pressure of 80. And then on the second slide there on voiding, she does look obstructed. And so Professor O'Connell, maybe you can tell us kind of thoughts on management for this patient.
Yeah, I mean, it is interesting that there is some literature that I alluded to about this combined situation, and it's difficult, isn't it? Because you're worried that you're going to make sling obstruction worse if you put in a sling at the time. And so it was a very clever study by Ginsberg and Rovner to actually pull data on two different approaches. And certainly where existing ISD or intrinsic sphincter deficiency is present, you're going to have to do a pretty significant urethrolysis, and so mobilize the urethra, you know, and put traction on the urethra during your urethrolysis to make sure it's now mobile before you go ahead with placement of a fascial sling. But, you know, in these, they're not hugely common cases, but they're also not super rare. It looks like it's a reasonable thing with a well-consented patient to do that combined procedure.
Yeah, so that's what she had done. Sorry, go ahead.
I agree this is a tricky scenario because the patient has ongoing obstruction, which we have to release. But at the same time, she's got recurrence of a stress incontinence. So if we put another sling in, the patient will be concerned, is this going to obstruct me again? And as Helen alluded to, I think the overall incidence of that is probably still quite low. I've read a paper mentioning about 8% of that happening. So, yeah.
And so that's exactly what she had. She had urethrolysis and a very loose sling that was placed at that time to given her stress incontinence. And consequently enough, she also had the synthetic sling removed, and that was sent for histology, and that was previously shown here. Beautiful slide showing sling with some chronic inflammation, vaginal tissue fibrosis, some giant cell reaction, and then on the second image there, positive culture. The last question I'll ask maybe for you, Dr. Ghani, to start off with, in cases where you don't do a pubovaginal sling at the same time and the patient develops recurrent stress incontinence, what is your next steps in terms of managing that?
So this is after urethrolysis or division of the sling?
Yeah, that's right.
Yep, I'll assess the degree of incontinence. So there are various techniques that we can consider afterwards. Transurethral bulking agent is often quite effective in this scenario, or a redo sling.
Great, so there's no questions right now on the online forum, but I will leave Professor Helen O'Connell to maybe kind of close our session and bring our ICS live event to an end with the final message.
Thank you, Garson. And I am going to see if I can share. Go to slideshow. So we want you to all feel excited about ICS 2021, which is hopefully going to be in a different world to what we're currently experiencing across the world, hopefully a vaccine and a great opportunity to get together physically, you know, have some great events like we had in Gothenburg last year. Anyway, we are certainly envisaging a great time to be had a little bit more than 12 months away. So with no further ado, will I, Mr. Chairman, close the session and say,
yes,
make plans for ICS Melbourne.
Well, thank you. Thank you both to you, Professor O'Connell, and Dr. Ghani, and ICS, and everyone for tuning in today. Thank you and goodbye.
Thanks,
Bye-bye.
Carson. Bye.